Hey, welcome, welcome, welcome. You're tuned in to another episode of
Sistars in Medicine.
I'm Akila.
And I'm Samia. And we are so glad you're joining us today for episode 3.
Yes.
We're going to be discussing a very important topic today. But before we do, let's have a brief recap. In the last episode, we talked about our personal journeys in medicine and how we navigated medical school, nursing school, and our respective specialties. Today, we would like to home in on medicine as it relates to historical trauma and mistrust.
Yes, and this has been a conversation we've privately had for years prior to becoming providers. We've long felt the need to unpack and understand the history of medicine and how it's shaped so many of our experiences, our interactions that we see with our patients, and how we individually have felt as Black individuals in this space. This ongoing conversation will serve as the framework and foundation for everything we will further discuss on this podcast. We'll explore how historical injustices like medical experimentation, segregation, and systemic racism have shaped the healthcare system, and how these lingering effects of these issues continue to influence the trust or, lack thereof that marginalized communities have in the system itself.
Absolutely. And we're also going to touch upon ways these deep generational wounds shape health outcomes and why it's hard for certain communities, and in particular Black communities, to trust the healthcare system. For me, trust operates in two arms. There is that of which occurs between individuals, me and you, which occurs over time and is established through consistency and reliability. And then there is historical trust, one created from collective lived experiences of people that is shared over time and sort of hand down through generation. Trust is a large part of medical care. And unfortunately, so many have been let down by the medical system in the United States. I can't necessarily speak to other healthcare systems, but I can definitely speak to the one here in the United States. We'll also talk about the possibility to heal and rebuild as a community, and how, as providers, we try and meet our patients where they are, and understanding that we are operating in a system that doesn't necessarily serve them.
For sure. But before we dive into this heavy topic, how about we do a quick check-in, a quick pulse, a little pulse check. How are we feeling today, inside and outside of our practice? Samia, how are we doing today?
I'm tired. It's winter time, and it is 6 months deep into the third year of residency training, and I'm exhausted.
Yes.
It takes a lot to get up during the winter time and continue to kind of grind it out in the day-to-day for residency. But I think that I got a vacation coming up, so getting ready to feel restored and rejuvenated for these last 6 months of my family medicine training.
How exciting.
Yeah.
Almost there.
Almost.
I'm going to kind of mimic your experience right now in terms of it's winter. I'm exhausted. As providers, we will have those times where we do feel exhausted, and it's kind of like that for me as well. It's the end of the year. So many births have been happening for me in my practice that I work for. So just super busy with 24-hour shifts, call shifts, clinic work. It's just been very overwhelming to a certain extent, but I'm just very grateful to be in this space and provide care to my patients. But like I said, I'm tired.
Yes.
So I am looking forward to a few days stretch off as well to kind of replenish myself, refocus my intentions. So that's kind of where I'm at as well. All righty. So let's get into it. Let's
do it.
Start talking about the legacy of historical trauma in healthcare. So there are so many layers to understanding the trauma and mistrust that exists within the healthcare system. So when I literally sat down to think about medicine and healthcare in general, I thought about early medical practices and how they closely are linked to either religion, spirituality, with healing often centered around the rituals and herbal remedies, and also faith. And as medical knowledge advanced, treatment methods evolved, shifting toward a more scientific approach and empirical understanding, meaning the observation of disease. However, the shift in focus on scientific and medical practices overlooked social, cultural, and of course, ethical aspects of healthcare in general.
Absolutely.
Including disparities to access to care and the exploitation of marginalized communities. And specifically for this particular conversation, for this current episode, when I speak of marginalized communities, in this context, I am speaking of people who experience discrimination or exclusion based on race and ethnicity. I wanted to kind of solidify what we're actually talking about when we talk about marginalized individuals. When we talk about historical trauma in healthcare, what exactly are we talking about or honing in? And like I said, it's a very complex and deeply ingrained issue, which touches upon the lasting effects of systemic racism, exploitation, and mistrust between marginalized communities and the medical institutions themselves. For example, when we talk about things such as the Tuskegee experiment or forced sterilizations, which are direct violations of human rights and medical ethics that continue to shape how certain communities, especially Black communities, Indigenous communities, and people of color interact with healthcare systems today. I know many individuals out there have heard of the Tuskegee study or the Tuskegee experiment, but don't fully understand what actually occurred. And I always hear like different points of views of what actually happened. So I just kind of wanted to address what the Tuskegee experiment was, which was a study that was basically grouping an individual group of Black individuals between 1932 and 1972, and one of the most infamous examples of medical exploitation. For decades, Black men in Alabama were told they were receiving treatment for syphilis. But in the reality of it is that they were untreated, though penicillin was made available in 1947 as the first line for treatment. As researchers studied the natural progression of this disease on this particular population. It's important to note that this wasn't an isolated incident. Rather, it was a part of a larger pattern of discriminatory medical practices, where marginalized populations were treated as expendable in the name of science. And I'm using my air quotations, science. This kind of deliberate neglect not only led to needless suffering and death, but also created a deep-seated mistrust of healthcare institutions among Black communities. As I stated before, for sterilizations, this particular act is an infringement upon reproductive rights. Particularly targeting Black women, Indigenous women. It was rampant in the mid-20th century. These procedures were often justified with pseudo-scientific claims of eugenics, a movement that sought to control population growth by preventing certain groups from reproducing. A belief that certain practices could improve the biology and genetics of a human race, with white, able-bodied people being considered the most fit representation of good genetics. The women subjected to these sterilizations were often coerced into consent through manipulation, lack of proper information, and deceit. In some cases, they were told that sterilization was a routine medical practice or that it was necessary for their health, when in reality, it was an act of racial and social control.
Speaking of racial and social control, I'm going to ground our next discussion in the work of legal scholar Dorothy Roberts, who I adore and spent a significant amount of time in my undergraduate career studying. In her book titled Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century, she discusses, in so many words, the problems with using race-based medicine. She even has an excellent TED Talk about it if folks want to watch that and do their own sort of research. Here we do encourage people to not always believe everything that we say, but definitely double check it. But in her book, she has this lovely quote that I like to read. Is it okay if I read a little segment?
Yes, let's hear it. I love it.
Thank you. So she says, the Human Genome Project, which mapped the entire human genetic code, proved that race could not be identified in our genes. On June 26, 2000, when President Bill Clinton unveiled the draft genomic sequence, he famously declared that human beings, regardless of race, are 99.9% the same. Contrary to popular misconception, we are not naturally divided into genetically identifiable racial groups. Biologically, there is one human race. Race applied to human beings is a political division. It is a system of governing people that classifies them into a social hierarchy based on invented biological demarcations. So what is Ms. Roberts talking about right there?
Definitely. Let's get in on that.
Yes, she's essentially saying that race is a social construct, that it doesn't exist within our genes, that in fact, if you pull two folks, run their genetic codes, you can't tell what race these folks are. That's what the science, especially the Genomic Project, highlighted for folks. But by acknowledging that it is a social contract, she is identifying the power that exists to demarcate a system that creates people on top and folks on the bottom. And science nowadays would have you think that that is inherent in people's bodies, that because you are Black, you are inherently supposed to be at the bottom of the totem pole. But when in actuality, that is not true. So when we're talking about race-based medicine, knowing this context and understanding that race is a social construct, it's not something that's actually made in our genes, you find that in medical practice and modern medical practice, which I will say I'll identify as the 1930s to present, has used different types of tools situated in this idea that people are different based on their race. We're going to talk about a couple of those examples because these things actually have been harmful overall and impacted Black people individually based on these false ideas that something is different genetically about Black folks. So, for example, there's a well-documented history of medical racism or race-based medicine, which is what we're talking about, which includes harmful stereotypes and false beliefs that have shaped treatment practices. One such enduring myth is that Black people have a higher pain threshold than white people, that there are biological differences between Black and white individuals that makes it higher pain threshold for Black people than there are for whites. This misconception has been used to justify undertreatment, no treatment, dismissal, or ignoring actual pain that Black patients have, leading to significant disparities in pain management and medical care. Talking about this reminds me of a lecture that I was sitting in when I was in medical school. There was a professor who will not be named, but was a cardiologist, and he shared to the classroom that Black people, descendants of enslaved folks in the United States, had higher levels of hypertension because of their genes, and that they were salt sensitive, which I just thought to myself, what is this man talking about? He said, because of the actual journey through the Middle Passage, that sort of meddled with Black people's genes, and it created salt sensitivity in their genes, which predisposed them to having higher rates of hypertension. Now, this man was saying this to an entire classroom of future doctors. What he was talking about is not based in fact. It's actually not even a true study when I even was Googling it in the classroom, because I said, what is this man talking about?
Yes.
It's actually even a hypothesis that has been disproven over and over again, but yet this older doctor was sitting here in front of this entire classroom trying to articulate the reason why Black folks have higher rates of hypertension, which is not actually based in any truth or any fact, which could really distort how these future doctors would practice and treat their Black patients.
For sure.
Now, our class wasn't having it, okay? We had quite a few Black people in the room, and with love, for me, I'm saying with love to myself, they all objected and raised their hands and was just trying to not poke holes, but actually get rid of what this gentleman was presenting to the classroom.
Right.
So I was very happy to be in that classroom. I was one of those folks that raised my hand, and it was just completely inadequate. but also that this was just an example in my classroom. So I know for a fact that this is happening around the country in other medical schools where folks are
Right.
being taught this information.
And being that this is a lecture that your class set in, I'm sure there have been years and years prior to your experience where he was regurgitating this rhetoric to plenty of other medical students. So definitely, I'm glad that you guys challenged him. Maybe he'll, not saying that he will, but just the fact that you guys did challenge him, maybe he'll get to start thinking about what he's speaking to in regard to that topic.
Yeah, absolutely. Other ways that this comes up in our medical practice, and I'm sure that we both have experienced this, is something called GFR, which stands for the glomerular filtration rate. It is a number that reflects how well an individual's kidneys function. And it also helps providers detect kidney problems early before symptoms even show up. So the GFR is calculated using a formula that includes a patient's race, specifically whether you are classified as Black or not. When it comes to Black patients, this correction factor adjusts their GFR upwards. Okay, that's upwards, meaning their kidney function might be calculated as better than it actually is. So even if a Black person has some level of kidney disease, the way that that is sort of processed is that it's kind of normal because they're expecting a higher number to be met in order for a Black patient to have true kidney disease. Mm-hmm. This is different from a white person, for example. And the GFR is also something that is used when trying to determine whether or not a person can actually receive a kidney donation. So it's kind of hitting you in two-pronged ways. First, it's not really classifying the actual level of disease that is present for an individual, and it is also preventing someone from getting access to a kidney that they might need.
For sure.
That is a huge, huge implication in someone's overall health and health outcome. Because with us, primary care folks, myself, mostly I'll speak, as a family doc, there is using the GFR and just getting a sense of like someone's level of kidney disease. There are some interventions that you can make specifically around nutrition, which can stop the progression of the disease. It doesn't stop you from having kidney disease, but it allows the slowing down of the progression of the level of disease that you may have. This adjustment comes from a historical belief that Black people have naturally higher muscle mass or a different level of creatinine, which is a waste product that is found in the blood compared to white people. Gotcha. Now they're saying that a little grandma who's about 90 years old and is 5'6" has higher muscle mass in her body than a 32-year-old 6-foot white male.
Got it.
That's the basis of how that has been formulated.
Yeah, so that entailed would, like you said, probably delay diagnosis of kidney disease, lead to less aggressive treatments if that's the case.
Mm-hmm. Absolutely. The other piece that I wanted to talk about, too, is something called pulmonary function tests. And these are exams that we usually typically have folks go under if someone is coming to the office and they're saying they're having more shortness of breath. And it helps us kind of diagnose the difference between something like asthma versus what people might hear of a COPD or chronic obstructive pulmonary disease or emphysema. And the pulmonary function tests have long been sort of controversial because the basis of the race utility in the pulmonary function test states that Black people have lower lung capacity than white people do. The American Academy of Thoracics has wrote an article in 2021 which stated that this is problematic, and they're not 100% sure how this could sort of impact health outcomes, but they do understand that it is rooted in the basis of something that is not inherently true.
For sure.
Some of that information from an article that I read many years ago had said that this idea that black individuals had lower lung capacity was a reason for them to be working in the fields because it was going to build up their stamina and increase their lung capacity. So a lot of that is still rooted in some very deep anti-Black racism and justification for enslavement. In addition to the pulmonary function test, there's something called a pulse ox. You know about a pulse ox?
Yes.
Okay. So it is widely used as a medical tool that measures oxygen saturation in a patient's blood, which helps to monitor their respiratory function. However, this technology has been shown to have significant limitations, particularly when it comes to its accuracy in people with darker skin tones. Studies have revealed that pulse oximeters tend to overestimate oxygen levels in individuals with darker skin, leading to potential misdiagnoses and delayed treatment. This discrepancy is due to the way in which the actual device works. It is relying on light absorption in blood vessels, which is how they estimate the oxygen saturation, which actually doesn't absorb the same way in darker skin.
Definitely. Yeah, so I want to switch into my space in terms of utilizing tools that utilize race in order to guide diagnoses or treatment or the likelihood of success for certain things. So within the women's health aspect and spectrum, there's something called the VBAC calculator. The VBAC stands for vaginal birth after cesarean section or C-section. It is a tool that is utilized to estimate the likelihood of a successful vaginal birth. This calculator is problematic, just like the pulse ox or using GFR for Black women, because they are disproportionately classified as higher risk when utilized in this calculator. It is also less likely that Black individuals will be offered a vaginal birth after C-section utilizing this tool, even when clinically appropriate. As Samia stated, race is a social construct, not a biological determinant. And using it as a factor in predicting health outcomes can reinforce harmful stereotypes, like you stated before, and systemic discrimination. This calculator subjected Black women to unnecessary C-sections, which are associated with higher risk of complications for both mother and baby. This calculator was developed in 2002, was noted to have concern for bias and poor outcomes in Black women in 2010, and then was only recently corrected in 2020 to exclude race as a factor for vaginal birth success. So it took that long of time for them to correct something that they knew was not beneficial to Black women. So another thing within the women's health care space is the utilization as race in determining risk factors for something such as neurotube defects, such as spina bifida, or even chromosomal conditions or abnormalities like Down syndrome, and that is the utilization of maternal alpha-fetoprotein. It is tested during pregnancy to screen for potential fetal anomalies. This test measures the level of alpha-fetoprotein, a protein produced by the fetus in the mother's blood. By incorporating race-based assumptions into this calculation, healthcare providers may misinterpret normal variations in alpha-fetoprotein levels as signs of abnormalities. Black women will experience an increase in unnecessary follow-up testing and potential procedures, including amniocentesis, which carries a risk within itself, as well as the decision to continue a pregnancy based on a false diagnosis. This practice is continued today. As a provider and an advocate in my space, I delegate to my clinical staff, my clinical MAs, to exclude race when we are submitting maternal alpha-fetoprotein screenings for our patients. And I just want to educate the masses that this is happening, at every practice. And I would highly recommend that you advocate for yourselves that they exclude race and maternal alpha-fetoprotein. So when you're in your clinic, when you're with your doctor or your OB, or when you're with your midwife, if you are a Black individual or an individual of color, when they start to speak to you about screenings specifically for maternal alpha-fetoprotein, I would highly suggest that you tell them to exclude your race. Okay.
Absolutely. And I just wanted to add to that, after we talked about that ourselves, when earlier in the year we came across the research articles that were talking about the utility of race for alpha-fetoprotein. I actually shared that during a sort of learning session with my residency cohorts, so that they're the doctors who are in training who became aware of that. And a lot of people had never heard of that. Even the individual who was doing the presentation had not heard about the use of race for maternal alpha fetoprotein. And in fact, during that session, when I mentioned it, someone did a Google search, and the University of Washington produced an article in the last 2 years,
right,
discussing how it actually should not be utilized when determining or screening for AFP in patients.
Yeah, it's shocking and surprising. And I actually had to educate my colleagues at the practice that I'm at, and I continually re-educate and reiterate that this is being used so that when they are in clinic and I'm not present, that they're being able to convey this to and delegate to our staff, because a lot of people still don't know. And it's very important.
I agree.
Okay. Now, honing in on some other aspects of the historical impacts of what is going on that impacts, trauma and mistrust in the healthcare system is segregation. The history of segregated hospitals is not merely a chapter in the past. It is deeply woven into the ongoing narrative of healthcare in this country, in the United States. During the era of segregation, Black and white patients were not only assigned to different hospitals, but the institution designated for Black patients were often underfunded, poorly equipped, and understaffed. And that still is happening and very apparent today.
Absolutely.
This disparity in care was not just a matter of separate facilities. It was reflected in a broader systemic devaluation of Black lives, Black bodies. Black patients received lower quality treatments, had limited access to advanced medical technologies, and were frequently denied the same level of expertise and compassion that white patients have received and still do today. The legacy of these inequities still linger, creating a historical distrust and fear of the healthcare system within itself, but also within the communities of color that experience these historically. For many, these past experiences are passed down through generations, inform their current interactions with healthcare providers. Mistrust is not simply born of recent events, but is deeply rooted in a collective memory of medical abandonment and harm. As such, the scars of segregated healthcare continue to shape how individuals from marginalized communities navigate and experience modern healthcare, often with skepticism and apprehension toward an institution that has historically failed them. These traumas are not isolated in moments. They are enduring forces that continue to affect patient outcomes, health disparities, and the way communities of color perceive medical establishments today. As I talked about how it historically impacts through generations, right? So there is this intergenerational trauma that plays a crucial role, and these historical events are transmitted across generations. The pain, the fear, the mistrust that stem from these experiences are passed down, influencing not just individuals, but whole communities.
Absolutely.
When people are taught to fear the very institutions that should be protecting them, it affects not only their willingness to seek care, but also their ability to trust doctors, nurses, researchers. And we saw that. We saw that in the past recent years with the COVID. We saw this mistrust. We saw the questioning in terms of research and what that means to Black communities. This fear can even discourage future generations from pursuing careers in medicine, which further perpetuates the cycle of inequality. This ongoing legacy of healthcare injustice means that efforts to heal these wounds require more than just acknowledging the past. It requires a radical transformation of the healthcare systems to be built, to rebuild that trust. We can't just acknowledge and say, like, okay, there's this mistrust, but now I'm different and you can trust me.
Yes.
There needs to be a whole reconstruction of the healthcare system in order to regain that trust and provide for our patients.
Absolutely.
Addressing historical trauma in healthcare must include policies that specifically aim to dismantle systemic racism, increased cultural competency among healthcare providers, and that's beyond taking a class.
Oh, yes.
It's an ongoing cyclical thing
Yes.
that never stops. This is one of the things that really, really bothers me when it comes to healthcare institutions and how they want to quote unquote increase cultural competency while providing an online course that people 99% of the time do not listen to, do not read, and just click through to the end to say that they've completed it. That's the basis of cultural competency that institutions have for individuals in healthcare. It's mind-boggling and at the same time despicable.
It is just a checkbox. They
just a checkbox.
Completed in next page.
Yes. And to ensure that communities most affected by this trauma have access to care that is not only competent but also compassionate. Without such efforts, the wounds of the past will continue to fester, hindering efforts towards true health equity for everyone. And that deep sense of mistrust has a ripple effect that goes beyond just the medical field. It impacts how families approach care, how people of color advocate for themselves, and how they experience healthcare institutions. It's real, it's powerful, and it's still present.
Absolutely, very much so. I feel charged up just listening to hear you say those things, because a lot of that is really a part of sort of why in a certain our whys in a certain sense of why we're doing this work, though we know inherently that the system was never meant, and I'm speaking true to form for Black people, was never meant really for the health and well-being of Black people. In fact, there's an extreme level of trauma that Black people endure every time that they show up and go to the doctor, because the system is like, not for you, not for you. How can I push you out? How can I push you out?
Definitely.
So I feel charged up.
Yes, I want you to feel charged up. These are the kind of conversations that I want our audience to feel charged up about. I want you guys to further delve into research yourselves and uncover some of these inequities that exist and the reasons why. Like, we're having these conversations about the historical aspect of mistrust and trauma so that we can further understand why Black communities are in the space that they are. It's not because of, you're doing X, Y, and Z to impact your health and that's why you're not doing well. No, it's a more complex picture. And as we've addressed systemically, that has an impact on overall well-being of individuals, specifically Black individuals and communities.
Yes, absolutely. And I think that for me, I am someone who's very much interested in tearing it down.
For sure.
I'm not a reformist, to say the least.
I know this.
But one thing I did want to talk about that you highlight in what you were just saying has a lot to do with this idea of mistrust. And speaking to kind of the opener is just that a huge part of care, not just medical care, but care, period, is someone's ability to trust the person who they're in partnership with to start that journey of healing and to start that journey of care. This is something that is very much eroded in the United States healthcare system, especially between the relationship that Black patients and Black people have with the healthcare system. I have patients who tell me straight up that they do not trust doctors. Like, it's literally, I'll walk into the room, we'll begin a conversation, and they'll tell me about some of the things that have happened to them, and right away they tell me that they don't trust doctors. And I can sense it in their sort of hesitancy or also fear in trying some of the treatment plans that are even discussed or even coming in and showing up for appointments. Definitely. There is this ingrained skepticism, which I think is rooted in some very real things. So I think it's an actual healthy ingrained skepticism. And who can blame folks for feeling this way, especially since time and time again they have been violated. Their health has been violated. Their concerns have not been heard. What they come to for the forefront is oftentimes dismissed.
For sure.
I have a patient who has literally, they're in their 60s and they have only really been seen in the last 30 years, maybe 4 or 5 times by a doctor.
Right.
this individual has very high blood pressure. And I'm actually, because we're talking about it today, I'm actually worried about their kidney function.
Yeah.
But just the first things that I'm working on with this person is really just building a relationship with them, because right when they come into the visit, they are visibly nervous, scared, shaking. There's like their whole body is sort of turned in. They're like arms are crossed, sort of protecting themselves. And when they talk to me, the eye contact is very limited. They just very short answers. They don't want to talk about much of medications or options. There's a lot of resistance there that I think is rooted in some very real trauma that this person has experienced. And so I spend most of my time in the visits with this person really just relationship building.
Yeah, when you don't feel like a healthcare system is designed for you, you're not going to trust them. And that's what they've experienced and what it sounds like to me.
Mm-hmm, absolutely.
Yeah, and so I've had very similar experiences, and I'm going to just speak to my current experience as a midwife in the women's health spectrum. Currently, I'm at a practice where, unfortunately, I am the only Black provider within this space. So I have encountered several patients that have come into the practice and straight up say, I'm specifically here because I saw you. They specifically say that they are very concerned about the statistics surrounding maternal morbidity and mortality, and they're here specifically because I exist.
Yes.
And when I hear that, not only do I feel a great responsibility in order to show up for these patients, but at the same time, I feel angry that I am the only option within this space that they have. And so the way that I navigate that is that I reassure them. I let them know that I'm here for them. I let them know that if they have any questions or concerns, regardless of what provider that they are seeing throughout their prenatal care, that they could always reach out to me. They could always send me a message. They can always request me as their primary midwife. But at the end of the day, I am only one person. So I have to, kind of recenter myself every time I have these interactions to kind of engage in that self-talk that you can only do so much. But patients specifically have been coming to this practice because I exist, and that's a powerful thing. Their trust is within me. So I haven't had necessarily experiences where patients are withholding information because of the fear of the medical space, but actually like regurgitating all of the things to me and letting me know that their trust is in me to help them have a very safe prenatal space, a very safe labor and delivery space. So I am very intentional when I have these patients because I know that they're there for safety.
Absolutely. And it is powerful just being able to create a safe space for someone who has historically not had a safe space.
For sure.
Like that. It is a lot, and I experienced something similar too with my primary care patients. Just when they see me and they open the door, their eyes light up. It's a very different experience. They're like, "I didn't even know you were here." I'm like, "That's okay," but I do feel that weight and responsibility in terms of wanting to provide the best care that I possibly can, understanding that we are limited both with time and space and what the system is, but just being able to create a safe space for someone is hugely powerful, especially where they have not felt safe before.
For sure.
This lack of trust in the healthcare system is deep, right? It's far-reaching, and it has consequences that in particular have a huge weight on health outcomes. When folks don't feel they can trust doctors, hospitals, insurance companies, they are less likely to seek care in the first place because there's just this instinct that it's not going to be helpful. They're less likely to follow medical advice or specific instructions. Preventative care, such as regular screenings, vaccinations, or early intervention, is often sidelined. This is a major problem because many diseases like cancer or heart disease are much more treatable when caught early. When people delay seeking care or avoid it altogether, they can end up having more advanced or often more complex health issues that could have had been prevented with early intervention. This means that when they finally do seek treatment, the problems are much harder and more costly to manage.
Right.
It's not just a matter of inconvenience, it's a matter of life and death. And that's something that is not just on the individual, right? That's something that is very much created by the system that currently exists.
Right.
And when individuals experience these poor outcomes as a result of these delays, it reinforces that cycle of mistrust, right? Because you're showing up and now you're telling them that they're dying. And this is why they didn't want to come to you in the first place. How are you helping me in this time of need? Mm-hmm. A person might feel like their initial concerns weren't taken seriously, or that the system failed them, which kind of further erodes that confidence like we were talking about in the healthcare system and providers. The mistrust spreads, and it's not just for the person, but also for communities who already face systems of barriers to even accessing care in the first place. The absence of trust becomes both a symptom and a perpetuator of health disparities, right?
Yes.
Ultimately, this erosion of trust isn't just, like I said before, an individual issue. It's a public health crisis at its root, right? Because preventative care and early intervention are crucial in reducing overall health costs. People are always talking about the money, aren't they? And improving quality of life. But when people feel unsafe, uncared for, unnoticed in a system, everyone suffers. The longer this cycle of mistrust persists, the harder it will be to reverse, and the more entrenched the healthcare inequities will become.
Exactly. And as we said before, as healthcare providers, we have to recognize this history, and that's why we're having this conversation. It has very real effects on our patients currently. We have to do the work in rebuilding the trust, and that's actively building, not just hoping it will happen on its own, not hoping that, your colleague will do their work and, change that perspective, but the actual work has to be within the community. And that is being in spaces that are hiring individuals of color to be providers, to be doctors, to be midwives. That's where it starts first. So when you have providers that are reflective of the community will automatically, naturally have trust within that particular individual because they see someone who looks like them. And that's also actively going into the community and letting them know that we exist. There are a lot of, like we talk about healthcare access, a lot of individuals don't know that it exists in this space because they don't necessarily have the internet or they're not on social media, because a lot of the times these individuals who come to me, they've seen me on social media. They've seen my picture. They've seen my face. I'm not yet in the space of word of mouth, one day, because I'm very new, but they have these social spaces where they're able to encounter the place that I work at, and they see that I exist there. So, being present within the community as well. Also looking into policy change. Like you said, a lot of the times we're in this space of, repetitive cyclical issues when it comes to systemic racism and how it affects our patients. And we keep talking about it, kind of like how I, talked about it in the first couple of episodes. Like, we always are talking about it. We're always having conversations, but nothing is being done. Like, we're tired of that. We're providers and we're tired of just talking about it. Let's actually put the work into it. And sometimes that looks like policy, and that looks like changes within our infrastructure of the medical institution within itself. So that's kind of where it needs to start. But for ourselves, I can speak to myself. What I have done specifically within my own practice is created a program. Hopefully, like I said before in a couple of episodes back, that it will get funding. And that is to specifically reach out and have support for BIPOC individuals within the maternal space. And that's for mental health. That's for, general nutrition and guidance so that they can have better outcomes. So we have to be more active. We can't just sit here and have these conversations and never act on them because nothing is going to change. We have to, like you said, dismantle the infrastructure.
Absolutely, which you've already just started kind of leaning into, which is just the next part of our conversation. As I've said, I am someone who's very much into tearing it down, all of it, burn it, start over. And the reason why I feel that way is actually is deeply rooted in the fact that any sort of changing or rearranging is still using the same exact tools, wood, building material, whatever you want to say, of the systems. And it's not actually taking a deep reflective look on how can this be something different, because we can't use the same wood. It's rotted. It's not going to hold anything up anymore. It has to be something different. So in that regard, I'm not necessarily also a solutions person, because I want us all to be talking about the same thing before we start planning what the next steps are in terms of solutions.
Yes.
But as you started to talk about, we are here in these positions, and we are in healthcare. So what can we as healthcare providers do to help rebuild that trust?
Right. And a part of that, like I said before, I feel like I'm repeating myself, but it needs to be ingrained into this conversation. It needs to be ingrained into those who are listening, that it's acknowledging the past. We hear this so many times within the realm of just existing, not even within healthcare. It's like, it's a part of the past, like move on. But we have to recognize that the past impacts the way things work in the future. And that's outside of the healthcare system. That's like saying, you're an infant and you put your finger on the flame and you got burned, but that was a part of the past. So I'm going to continually put my finger on the flame to get burned? No, I'm going to readjust the way that I approach this flame. I know that it's hot. I'm not going to touch it. It's going to be harmful. Moving on to the next step. So we have to be mindful of the language that we utilize when we are talking about and acknowledging the past, because it does have an impact on the future.
And a huge part of that is also the present, right? So it's like the right now and even the future to come is shaped and formed by things that have happened in the past. I think that in sitting here and kind of really processing the conversation, even though I am truly a radical, I think a huge part of beginning the process for folks, one day at a time, one thing at a time, but really creating the safe spaces that we were talking about, and how powerful creating those safe spaces are for patients.
For sure.
It is hugely impactful and transformative when a person truly feels heard in your interaction with them, as even just from the moment that they come into your clinic space. How is that person feeling? Is it inviting? Is it restricting? Do they feel safe here? And from the moment that they interact with you in that visit, is just being able to take a sense and really hear how they've experienced their own history, their own lived experience, their own interactions with the healthcare system, because people truly are the experts in their health.
Yes.
They are truly the people who know what feels good in their body, but that has been so removed from individuals in terms of autonomy for their health. But I think that they're the experts, and we're here to work in partnership to help them be whatever version that they would like to be.
For sure. Absolutely. And another way we can rebuild trust is by advocating for more equity in healthcare delivery. And what that means is, taking a look outside of the box, right? How we provide medical care.
Yes.
And within the last recent years, we've evolved in some sort of way with utilizing telemedicine, right? Video visits. This kind of expands the access to care and providing a more equitable space for people to receive, care.
Yes.
It's not enough to just show up in the room and be kind and let them know, yes, I'm a Black provider, but what else are we doing, right? We need to be active in making sure that resources and care are equitably distributed. And that means, like, for example, I'm in, like I said, a well woman space. And there are definitely options for taking prenatal classes, classes to what to expect for newborn care and lactation support and things of that nature, which everyone deserves to have access to, everyone deserves to have.
Yes.
But yet, in order to be equitable, we have to find a space where they can access it. A lot of these things are expensive. And in order to be equitable, we have to provide, maybe grant funded spaces for individuals, or sliding scales for individuals, or free classes for individuals. That's how we can provide an equitable space. But if that's not happening, you're not providing an equitable space. And I'm always having these discussions with the practice that I'm at. Like, how are we making this accessible and equitable for individuals who can't afford these classes? And these things need to be brought to the forefront. They need to be discussed, because that is how we speak to having equitable care. And I'm always an advocate for it, and I'm always getting looks for it.
Yes.
But it is what it is. Like, that is what I feel like my place is, and that's where my passion is.
Yeah. I think that also, what would it look like if not just you having to fight for this in your individual practice, because as you so eloquently highlighted, this is important for pregnancy well-being and the well-being of folks who are pregnant and their respective children that they're bringing into the world. What would it look like? Imagine, just come on a journey with me for a second. What would it look like actually if that was truly considered important for the entire country, where you wouldn't have to fight for funding for the things that are important to maintain a healthy pregnancy, that it would just be a given? That would be that's the kind of change and impact that we want to see, is where people don't have to fight for funding for things that are important for their health. That's just something that the nation knows that exists, because if you have healthy people, you have a better society, which then, if you're into the sort of like capitalist rage in terms of fighting for different countries and all of that nationalism, you actually are investing into your people, which then would produce populations of healthy individuals that can push that needle forward if that's the folks that you want to engage with. But I think that what you're talking about also brings up something that's more of like one of our guiding principles, which is community care. Right. So I touched on it a little bit when I was talking about how folks are the experts in their health. And historically, people kind of knew and understood what was going on in their bodies prior to us establishing these healthcare systems, where it said, you don't know what's going on, you have to come to us so that we can tell you what's going on based on your symptoms. But rather, a community-based health approach is kind of relying on the folks in the community to have an understanding of what's going on with their health and in their bodies, and coming to us practitioners just to work, again, in partnership with them to optimize their health.
For sure.
Community-based practitioners, I'm all about like truly investing in and supporting your doulas, your midwives, your other non-traditional healthcare providers, such as like your herbalist. Those are very important individuals that have always been historically present in communities, historically speaking, prior to the Industrial Revolution. These are how you would go to your community healer. So those are things that are inherent in that history and the fabric of communities that already exist, that I'm just really all about, like tapping back into that community health, that community wealth, and merging that with current systems that exist, which could start to help to rebuild that trust. That if you believe in some of the practitioners that I have in my community, you're validating them, you understand them, and you're offering maybe some other perspectives so that I have more of a well-rounded approach and informed consent about my health. That's starting to bring trust. So when people see providers, as you mentioned, who look like them, who understand their lived experience, it makes a huge difference in their overall health.
For sure. And we're going to keep beating this into our audience. We're going to keep having these conversations amongst ourselves. This is a long road, and it won't be fixed overnight. Rebuilding trust requires consistent effort, transparency as providers, and a commitment to changing the system. It's a continuum. You're going to continue having these conversations. Me and Samir are going to continue having these conversations with ourselves. I'm always going to be having these conversations with my colleagues. but we know that it's possible. More and more healthcare providers are recognizing the need to engage in difficult conversations about health and equity, race and equity, such as ourselves, and will continue to do so. But as I stated before, it's going to be further beyond having conversations. We're, planting the seeds, but we're here to move things forward.
Yes, and it's the kind of change that is truly needed. You have to be willing to learn from history, engage with it authentically, like truly engage with it, and be committed to doing better for our patients, communities, and ourselves. The work is hard, but it's necessary. I think that for me, that's something that I have been struggling with throughout my sort of training process in residency is how do I reconcile within myself that I'm working in a system that I do not fundamentally believe in, but I'm trying to provide access for folks who have historically not have access to this system,
Right.
to try and improve one's day-to-day health experience.
Right.
And I think that a part of that is my sort of deep sort of historical rooting, which allows me to say honestly to a patient who is Black sitting across from me, who has been having some negative experience in healthcare, that yes, that is absolutely right. What happened to you should not have happened to you.
For sure. Reaffirming their experience is one of the main things I think that is very important as providers, as Black providers to our patients of color, to let them know that they're seen, right? That's one of those main components. And I can speak to exactly what you just said in regard to patients when they're coming to us and saying, hey, this is what's happened to me. This is what my experience is. I want it to be different. Can I rely on you to have a different experience? And like you said, that's a very powerful thing to have, but at the same time, very grateful that we're able to kind of navigate this particular space for this patient and make them have a better experience and better outcomes. That's kind of like one of the things that drives me, in a sense, a part of my practice. I'm showing up for my patients. I'm letting them know that I see them, that I'm affirming their experiences, and that I'm going to do with everything within my power to make sure that their experience is different, that their outcomes are going to be better, because
Absolutely.
I navigate medicine that way. I'm really glad that we got to explore this topic today. It's not an easy one, but it's super important. In the next episode, we'll be talking about how representation in healthcare matters and why.
Yeah, and I want to say that there's so much more to talk about in this conversation, and this was just sort of a bit of an introduction of sort of our foundation and our guiding light through our main themes around what we'll be discussing as we move forward in this podcast journey of ours. But I think that I charge you who are listening to do, like as my sister said, to do your research. It's important to always know where the information is coming from. It's okay to just make sure that even what we presented here today is things that you can actually find resources to and find connection to. But I think that I'm really enjoying just hearing your perspective on some of these topics and just making sure that we keep having these very hard conversations, because I think it's important to always remember your history so you're able to know where you're going. And if you're enjoying what you're hearing, please make sure to like, subscribe, and share this podcast with others. You can find us on all major platforms, including Instagram, YouTube, and now Spotify.
We're on Spotify now. So we're so grateful for your support. I'm Akila.
And I'm Samia. Thank you for tuning in to Sistars in Medicine. Stay curious and be well.
And we'll catch you next time on Sistars in Medicine. Have a good one.
Bye.